Let me try to. So let me make sure I try to do. Okay, can everybody see my slide?
Yes.
Okay. Okay, wonderful. Thank you very much. I'll try to use half an hour. I might, run over time. I'm sorry about that because once I talk, it's very hard for me to shut up. But anyways, so I'm excited to share with you what I have learned from 2022 ASAM conference. Mainly, I just chose some slides also topics that are very kind of very relevant to our case. Actually, we just discussed the case Jennifer was about to discuss, and actually Elizabeth already sent to us. But not just the, I mean, ASAM is an annual conference. They have annual conference, American Society of Addiction Medicine, and a lot of experts from all over the world, and actually came to share, their experiences in treating addiction population and also doing research. So I just chose, a couple of topics kind of relevant to, to what we are doing here. So since the original topic was about methamphetamine use, so I want to talk a little bit about advances in treatment for methamphetamine use disorder. Now, first of all, very, very important, there's no FDA approved treatment. By the way, I tried to put all the presenters' names. Those are not my slides. I just summary. Some are summaries of the slides, some are kind of original slides. Okay, so I try to give credit to all original presenters. I try to put for this one, Dr. These names down, right at bottom of the slide, so you can see who actually originally presented the content. But anyways, so Dr. Chirati works for University of Texas Southwestern Medical Center. It's a very, actually a very large center, and he led a very famous methamphetamine use disorder clinical trial. Okay, it's called a CTN Clinical Trials Network 0068 ADAPT-2 study. So there was one ADAPT study, accelerated development of additive pharmacotherapy treatment for meth use disorder. So originally, it was a pilot study conducted some years ago by UCLA. So that study found a quite effective, actually, effect size, a big effect size from using combination. Now that one was an open study, only recruited, I think, only 20 patients, 20 subjects. So it was a feasibility study. So it was a combination of Vivitrol injection plus Wellbutrin extended release of buprenorphine oral extended release. So 450 milligrams. So from that study, about 11 out of 20 patients showed response. So that was very, exciting at the time. So then Dr. Chirati took over this new study, actually second phase. They recruited about 406 patients. They used, this is a double-blinded study. So placebo arm and Vivitrol plus buprenorphine arm. So those patients received the Vivitrol every 3 weeks, Vivitrol injection, 380 milligram, plus buprenorphine, 450 milligram, extended release. The results of this study have been published in New England Journal of Medicine. So it was a kind of, definitely new advanced, treatment for methamphetamine use disorder. It was fantastic. However, the results, the effect size was not really very good. So for placebo group, it was about 2.5%. Then for the combination medication group, combined medication group, it was about like a 16, I think it's a 13.6. So overall, the effect size was 11.1%. So in other words, 1 out of 10 patients from the study showed response to combination of Vivitrol plus Wellbutrin, followed up within 12 weeks. Okay, so comparing with the placebo group overall. So advances in treatment of methamphetamine use disorder, another study proposed, CTN 0132 study. So we all know dopamine is heavily involved, but we tried different things, right? We tried all different kind of medications. Now, wellbutrin is NDI, it works on dopamine. It's dopamine norepinephrine reuptake inhibitor. So also we tried, different studies also tried Vyvanse, tried Adderall. We're talking about dopaminergic medicine, dopamine agonist. So this study targeted glutamate neurotransmission. So we all know ketamine was kind of very, it's kind of effective for treatment-resistant depression. The ketamine has a rapid onset. So this study focused on IV ketamine for these patients. This is still going on. So they try, the patient population is methamphetamine use or cocaine use disorder. So we're talking about two types of patients, and the methamphetamine or cocaine use disorder. So far we still don't know, and they're still recruiting patients, but at least we know ketamine is so abundant. They said about like 90% of neurons, actually synaptic, talking about the synaptic neurons, they're actually glutamate related. We're talking about glutamate is such an abundant neurotransmitter in our brain. And we all know from previous studies, glutamate is very much related to Q related cravings. So we're talking about if patient has seeing something which kind of remind them, or kind of seeing a pipe or seeing somebody else is using cocaine or methamphetamine, that might just trigger their use. Now that kind of the biological mechanism, that kind of mechanism, actually we know glutamate is heavily involved. So this is a new avenue. It opens a new avenue for methamphetamine treatment. Now still going on, so we don't know, but this is this is another study. Promising. We're waiting to see the results. Okay, methamphetamine in pregnancy 2022, and unfortunately, and we know nowadays a lot of pregnant women they use the drugs and the opioid use disorder plus concurrent methamphetamine use. So now we know from this presentation, they presented a lot of problems associated strongly, we're talking about strongly associated with methamphetamine use during pregnancy. For example, we're talking about miscarriage for sure, right? And preeclampsia, talking about eclampsia and premature birth for sure. And we're talking about placenta problem, placenta rupture, all these kind of problems. So we're talking about overall methamphetamine is harmful both to mom and also to the baby. So there's no doubt this is such toxic drug. So, but unfortunately, not many studies have been conducted in this population. Well, we know why, because this is a sensitive population. It's very hard for you to study. Okay. Combined use, concurrent use of methamphetamine and opioids, we know now is called the fourth wave of opioid crisis, is on the rise for sure. I'm not going to talk more about this whole slide, but okay. At one center in Seattle, this is from actually the presenter's working place. She said since March 2020, out of 60 patients being treated for opioid use disorder, those are all pregnant women. 50 patients had a co-occurring use with methamphetamine. Now that is 5 out of 6. 5 out of 6 opioid use disorder pregnant ladies, they also concurrently used methamphetamine. That's 83%. And unfortunately, 24 patients were treated with mirtazapine. We know that was kind of effective in some special population. So in Seattle, Washington area, basically they tried to use this to help people with cravings. And that was a pretty safe medicine to be used in pregnancy, also for nausea, for sleep, for different kind of reasons. But at delivery, 5 patients, we're talking about 8.3%, almost 10%. Was still positive for methamphetamine in urine tox screens. So think about this. So they're pregnant. They're giving birth to babies, new lives. And at the time of delivery, about 10% of those patients still positive for methamphetamine. think about how problematic that is. So again, we need different kind of treatment options. Here we did a feasibility study for deep brain stimulation. You all know that. And also we had a TMS study and focused ultrasound. And other people actually also try the same thing. So neuromodulation could be a good option. Could be very promising. So currently approximately 200 TMS in substance use disorder articles since 2000. That is fantastic, right? 200 articles. Now this is CTN 0108 study. So they used the repetitive TMS in stimulant use disorder. They're still recruiting. It's a feasibility study. It's a methamphetamine or cocaine use disorder patients. So they try to focus here. They found like a high frequency 10 hertz TMS is kind of, amplifies the neural response. Now 1 hertz low frequency TMS, it kind of attenuates the neural response. So you want to stimulate the places where you want to stimulate. You want to attenuate the neural response in those regions. You want to, reduce the activity. For example, for like a cravings, we talk about emotional arousal, those kind of places, you want to reduce activity. And for other places related to your decision-making capacity, for example, like a dorsolateral prefrontal cortex. So they want to stimulate, use 10 hertz frequency, repetitive TMS. So they have 2 arms, sham and also real TMS arm. But anyways, this is a feasibility study, still recruiting. And also they have like a daily digital monitoring of cravings, use, mood, stress, sleep, like any other clinical studies. They also have CBT digital modules available, which is great. So they're not only using neuromodulation, they also include other very effective like treatment components. So yeah, feel free to ask me questions. Okay, like I said, I'm just sharing my what I learned here. So I personally also have a lot of questions. I think this slide is very, very, very important to us because think about what we're doing here. This is a SAMHSA 4 dimensions of recovery. So when we treat our patients, so we focus on abstinence. We focus on how many days they have been sober. So actually supporting a life in recovery, there are 4 dimensions you need to consider. The first is health. So overcoming or managing one's disease symptoms. You want that person to be symptom-free. You want that person to be not suffering from withdrawal every day, from like all this different kind of drug-related discomfort, okay, including physical health. But in the meantime, you want that person to have a home, to have a stable and safe place to live. And also purpose, that conducting meaningful daily activities. You want that person to be like one of, each of us. You want that person to hopefully, we're talking about it, to have activities, right? And also have a community, to have supportive friends and social networks. So think about our therapy, think about our peer support groups, think about all those kind of, treatment components. So what we are trying to offer here is a comprehensive treatment. So we're aiming at improving health, home, purpose, and community. This is in line with SAMHSA 4 dimensions of recovery. So we're talking about we're treating a human being, which we want them to be well, not just like not using. So that's very important. That's why I want to share with you. In terms of assessment of substance use disorder, yes, it is a disorder. We have DSM diagnostic criteria help us to make a diagnosis. It's just like diabetes, just like hypertension. And we have ASAM placement criteria that can help us to assess a patient, to move to the next level of care, to place patient in the right level of care, which is very, very important. If patient is still actively withdraw, then you cannot put that patient in a residential or IOP program, right? So this is very, very important. And also we have scientific way to monitor the compliance and treatment progress. For example, toxicology testing. I understand that we do not have a biomarker for the disease itself. However, we do have toxicology testing to help us monitor treatment progress. And remember, we have 4 dimensions of recovery. That's our treatment goal. Okay, finally, practice harm reduction. Keep in mind, at this time, we are doing harm reduction. So you think about if the patient has improved, even if a little bit, then you need to use that as an opportunity to motivate patient to engage into treatment more, to move to the next step. So this is a totally different treatment concept. I mean, as a clinician, we learn to help patients where we want to cure the patients. But in this kind of business, keep in mind, harm reduction is the first thing you need to do, because this is a life and the death matter, right? We understand that. So the neurobiology of addiction, now I'm not going to talk too much about this because basically, so mainly still they're focused on dopamine, and we understand the glutamate is heavily involved. And also actually recent article from Nature Medicine, they talked about the neurobiology of addiction. Actually, they found the connectome. We're talking about the connectivity, the functional and the structural connectivity in our brain cells, neuron cells, kind of play a very, very important role. Okay, not only just those regions. So there's a lot of things for us to learn, but no matter what, yes, there's neurobiologically, there's a foundation. We understand, we're trying to understand more and more about the addiction itself. So this is another summary from the same presenter. Basically, it's a chronic health condition. Addiction is a chronic health condition, and the stigma, not like many other illness, unfortunately, stigma actually gets in the way of treatment. Stigma has negative impacts on health and healthcare delivery. I cannot just repeat this, again. I mean, we have been involved in the ECHO presentation many times. We have separate lectures on that. So stigma reflect on our own inherent bias. Please, important, think about ourselves. And finally, harm reduction is a philosophy of care that embodies compassion, collaboration, respect, acceptance, and empowerment. So I think that it's all these things, each word, if you read it, you can think, you can have a lot of thoughts, a lot of, extended thoughts about, thinking about all these words. Yeah. Okay, another topic, substance use disorders and trauma. So we also published an article from here, okay, with Aaron Winstanley as the leadership. So comparing with those people who did not have adverse childhood experiences, those with 5 or more ACEs, they tend to more likely, actually 7 to 10-fold more likely to report illicit drug use problem. Think about this. Those people with more ACEs, they tend to have more substance use disorder. On the other side, 89% of clients seeking treatment for SUD had at least one traumatic experience. So in other words, from all those substance use disorder patients, a lot of people report adverse childhood experience, traumatic experience. And PTSD, of course, that's a bad, consequence, a common consequence, a common, associated mental health problem with ACEs. So it's very much related, and unfortunately, poor outcomes in substance use disorder patients if PTSD is left untreated. In other words, if we don't pay attention to the risk factor, ACE, then we may not be able to help patients. Just treating the addiction problem, will that solve the problem? Will that help patients improve the life, improve health? We're talking about overall the community and everything else. May not. So I think this is very interesting. One presenter actually discussed a lot about the female and the males, the difference in terms of pathophysiology, neurobiology of alcoholism. So females, we're talking about a lot of females try to drink, to self-medicate, to help them emotionally cope. So prefrontal cortex and amygdala. We know amygdala is very much associated with our emotional change. Amygdala is a place where when you feel anxious, you feel restless, and amygdala is overacting, right? And there's a childhood adversity. We're talking about a stress and internalizing disorders, different kinds of things. All those things can lead to alcohol use in female. But for male, it's different. The difference is still prefrontal cortex is involved, but the striatum, we're talking about ventral striatum, mainly we're talking about nucleus accumbens and olfactory tubercle. We know they are very much related to rewarding. now. So we know actually men, in other words, they tend to impulsively drink. They tend to seek like a sensational change. They tend to drink to feel just better, not just to self-medicate. No, this is just the overall, we're talking about pathophysiologically. Okay, this also is a kind of, we're talking about from the study results. So in other words, the negative, you see the peak from, we're talking about positive and negative reinforcement. So for females, the negative reinforcement is kind of, we have more patients that are trying to drink, to feel normal, to cope with anxiety, to cope with stress, to cope with like, past trauma. Okay. So in other words, it helps us. It's very important. Why is it important? Because it helps us, it guides us on what to do next. So think about a female patient with a lot of trauma in the past. Okay. A very bad, like, continuous abusive relationship. And very hard to function both at work and home. So you just give that person like an abuse. We're talking about the Vivitrol and Camprol will help with cravings. But have you solved the problem? Have you ever thought about what's really going on? What has been the main pathophysiological change in that person's drinking behavior? So actually, we should target stress system. We should target actually paraventricular nucleus or locus coeruleus. In other words, we can use noradrenergic targets. Naguafacin, which is alpha-2 agonist, and doxazosin, which is alpha-1 antagonist, and also kappa antagonist. We know kappa receptors of opioids. They're very much related to anhedonia. We're talking about, right, and talking about depression and all these kind of symptoms. So glucocorticoids. So in other words, we may need to use different kind of medications in addition to craving medications to help with cravings, right? So think about that. So next time when you see a female patient drinking in your clinic, and what else you need to ask? What are the things you need to assess? And what are the medications you can consider? And those medications are pretty benign. They're not even psychotropic medications. We're talking about guafacin and doxazosin and carvedilol, and those kind of medications. Basically, we use it all the time in to control blood pressure, right? And to control, like guafacin is a medicine we use for even child ADHD, those kind of things. Anyways, so summary and conclusions from Dr. McKee. Stress is a major factor in the initiation and maintenance of alcohol use disorder in women. Keep in mind. And treatment development for women with alcohol use disorder need to target stress pathophysiology, particularly following the impact of pandemic. And noradrenergic targets hold promise to target gender-sensitive systems involved in AUD. Studies need to be powered to examine sex differences, and results need to be presented by genders, right? Keep in mind, this is very important. Okay. I spent just a few minutes talking about this because this is very much related to our case. Buprenorphine dose limits. What is the evidence? Now, everybody here has been using less than 16, and 16 is our maximum. So Jennifer presented a wonderful case, and I was thinking about this case. That's why when I summarize those slides, I think this is worth presenting. So issues with dose limits. Think about this, okay? So prior authorization. So basically, you just cannot get authorized. So basically they don't cover more than 16. So what else can you do, right? 16 or 24, depends on the state. Pharmacy costs, insurer will not pay for more than 2 of any film dose. That's pretty common, right? I mean, you cannot just prescribe 8 milligram and 4 milligram or 2 milligram films. Many buprenorphine prescribers refuse to prescribe doses higher than 16 per day. I believe myself is one of those, and including the great Dr. Hirschler. And the limits, just kidding, actually, we do prescribe higher dose sometimes. But limits referral options for patients discharging from residential treatment. Think about this. A lot of times when I refer patients, if the patient is a high dose or patients are referred to us, sometimes we hesitate to take patients because they are high dose. So think about this. Those are all various problems. And why should we care about buprenorphine dose? Why do we care about it? Well, it's a matter of life and death. The reason is before 2015, you know, we have natural opioids. We have morphine, codeine, we have semi-synthetic opioid problem, pain pills, oxyhydro, right? We have illicitly synthesized heroin drug problem. And we even have talking about methadone as a 4-agonist. Of course, people cannot use methadone, abuse methadone, or methadone was a 4-agonist. But now what we have synthetic opioids other than methadone. We have highly toxic, very potent, and we have like commonly, you know, obtainable fentanyl. So that is the problem. You see this peak? So what else can we do? And unfortunately, realistically, there's nothing else available to help patients like this. So how many times you see patients urine drug screen positive for fentanyl now? So, I mean, we have been doing this for a while. So we're talking about like many years ago. I mean, urine drug screen positive for fentanyl was not really very common. Nowadays, it's so common since 2013, 2015. You see 2017, you see the change. So FDA buprenorphine naloxone package insert. It says dosing recommendations are based on data from trials before 2002 at doses equivalent to 6 to 24 milligram. So any dose above 24 milligram, not really beneficial. They recommended the daily dose for maintenance is 16. At the beginning, you might use 24, but then the maintenance dose was recommended to be 16. Okay, the maintenance dose is generally in the range of 4/1 to 24/6 milligram buprenorphine naloxone per day, depending on the individual patient. Dosage higher than this have not been demonstrated to provide any clinical advantage. Well, we do this per package insert. That's our guidance, right? So package insert told us basically it might not be effective, you know, after that certain dose. However, please read ASAM 2020 guidelines update. The treatment goals of our MAT with buprenorphine: number 1, suppress opioid withdrawal. Please think about the case you just read from Jennifer, okay? Block the effects of illicit opioids. Reduce opioid cravings and stop or reduce the use of illicit opioids. Opioids, right? Think about this. Now, Suboxone only works for opioids. We know that. Suboxone itself as a medicine. Now, we're not talking about the code clinic, okay? Now, promote and facilitate patient engagement in recovery-oriented activities, including psychosocial intervention. That's the key. I always tell my patients, this is the key. Actually, the benefit from code is not from Suboxone. It's the whole package. It's the counseling, is the structure, is the monitoring, is everything else. So if you cannot engage in that, you probably won't do better. So this is probably not a place for you. So this is what I got. This is my own slide, okay? So I got it from ASAM National Practice Guideline for Treatment of Opioid Use Disorder update. So basically, it says following initiation, buprenorphine dose should be titrated to alleviate symptoms. To be effective, buprenorphine dose should be sufficient to enable patients to discontinue illicit opioid use. That's number 1. The evidence suggests that 16 milligram per day or more may be more effective than lower doses. Please keep in mind, possible individually. This is limited. There's limited evidence regarding the relative efficacy of doses higher than 24 per day. And the use of higher doses may increase the risk of diversion. And there's no doubt about it. We can talk more about it. This is also my own slides. This is from the DHHR, West Virginia DHHR website. This is our policy. Maximum initial dose is 24 milligram for 60 days. So after that, it's case by case. You need to get approval, and it has to be a limited time, only to allow stabilization of the patient during times of crisis. And also maximum quantity limit is 2 dosage units per day. So keep in mind, please think about this. So here in West Virginia, if you want to prescribe more than 16, you need to get a pre-authorization. You may not get it. And also, then the patient may need to pay out of pocket. Then the pharmacist may call you as well. So it depends, okay? I can tell you all different kinds of my experiences. So a few more slides to go. Is my patient meeting ASAM treatment goals? First, any cravings, any time of day or night, any withdrawal symptoms, any time of day or night, any night sweats, any using dreams, any use of any opioid that is not prescribed for you and known to me. So think about this. Then this questions address short-term buprenorphine specific issues. Additional targets depend on relationships and mutual goals. So test the urine saliva, that's what we have been doing when clinically appropriate required. So talk about immune receptor occupancy. Back in 2003, this is the data. So if you use 2 milligrams a day, you occupy pretty much 27 to 47% of mu receptors. If you use 16 a day, you occupy 80 to 92%. If you use 32 milligrams a day, you occupy about 90 to 98% of mu receptors. Think about that, okay? That's the, so mu receptor occupancy conclusions. Buprenorphine dose dependently increased mu receptor occupancy. In other words, when you max it up to this dose, 32 milligrams, it occupies above 90% of receptors. There's no doubt. We know that, right? Okay. High receptor occupancy correlated with improved therapeutic effect. Now, there are a lot of studies actually in this slide set. I did not put all of them here. So of course, in this slide set, they're talking about high dose is kind of associated with high retention rate. High dose was associated with lower infectious disease rate. High dose was associated with some other benefits, okay? So decreased opioid withdrawal and reward symptoms. So near maximal effect occurred at 32 milligrams a day. Now, I'm not advertising, don't get me wrong, okay? I'm not advertising more than 16 a day. I can tell you more about, I'm a researcher. I can tell you more about what we have learned from our co-clinic. So our maximal dose is 16, there's no doubt. We have 550 patients now. We have treated more than 3,000 patients in 10 years. So, but anyways, so near maximal effect occurred at 32 milligrams. Think about that. Mu receptor occupancy review withdrawal suppression requires 50% of receptors. So in other words, if you give a patient the 4 milligrams a day, very likely that person will not have any bad withdrawal problem. If you give that person 16 milligrams a day, you're pretty much occupying 80% of the mu receptors, and you are blocking basically most of the subjective opioid effects. Now, finally, if you occupy 90% of receptors, give 32 milligrams a day, then you are blocking subjective effects of high opioid. We're talking about the subjective effects. So this is a very, think about this. The conclusion is we conclude that fixed arbitrary limits on buprenorphine doses in clinical care or limits on reimbursement for this care are unwarranted. So I guess everybody's different. If you check the package insert, so 2 milligrams, 4 milligrams, 8 milligrams, 12 milligrams, 16 milligrams. Actually, they found like a 12 milligram actually has the highest bioavailability. I think it's the highest, like 40 something. So, but everybody is different. So when a patient tells you, Doc, you changed me from 8 milligrams, 1.5 a day to 12 milligrams. So I feel better or worse or same. They all could be true. That because basically per package insert, the bioavailability is different. Just talking about the variability is very small. However, there was a difference found, okay? Not statistically significant. And also individually, the threefold or more we're talking about overall pharmacokinetically, the bioavailability could be different. We're talking about threefold, that's pretty high. So one person taking 12 might be really taking 12. The other person probably is just taking like a 4 milligrams a day. So that is a big difference, right? So think about that. So we're talking about, what I'm trying to say is, yes, theoretically from research, well, there is a difference, possible. So yeah, probably is low. Difference probably won't be very big, but yes, possibly there's a difference. So summary and takeaways, buprenorphine dose is adequate if patient perceives it as adequate. So ask your patients, please, reduced illicit opioid use. Reduced illicit opioid use. So when you do studies, we only do like most of the clinical trials, we study the opioid-free time, right? 3 days. Increase the retention. Now we have a total abstinence program. Actually, we are pretty successful overall in co-clinic. So our opioid-free time is, percentage is very high. Clinical and preclinical evidence that 32 milligrams a day or higher can be helpful for some patients, particularly those with pain. Pregnant women need increased dose of buprenorphine and increased frequency of dosing. That's for sure. That we can talk more about. I have 2 more slides, quick. What about diversion? Yes, there is a diversion. There's no doubt. And if you give patients more Suboxone, more buprenorphine, I'm talking about more, yes, the chance subutex has higher, street value for sure. And you give them more, very likely they would divert. I hope they have like a more like a detail, like a breakdown, like numbers for this, like how many people are high dose, how many people are low doses. But unfortunately, they didn't give us this. However, 50% of participants reported they have shared buprenorphine, and 28% reported they have sold buprenorphine. But think about this: 1 out of 2 have shared. We're talking about almost 1 out of 4, more than 1 out of 4 have sold buprenorphine, and about less than 50% have never sold, neither sold or shared their buprenorphine. So which is good. 22% agreed or strongly agreed that it's right to share buprenorphine with dope sick friend. You're seeing a friend who's using drugs and now is sick. Okay, that person will do whatever it takes to use. And it doesn't matter it's IV or it doesn't matter the dose. Doesn't matter it's fentanyl or something else. So 22% agreed and strongly agreed. So 37% agreed or strongly agreed buying or selling buprenorphine on the street saves lives. We're talking about, again, I cannot, I have to say it again. We're doing harm reduction. We're saving lives. So think about this. I know we're responsible doctors, but think about what we're doing. Okay, other people actually had more problems than us. So I think this summary is very good. Improving access to OAT by making it financially affordable is essential to further increase OAT coverage, and is one of the factors that can reduce the illicit market with OAT medications. Think about how to solve this problem. If everybody can get it easily, why do people need to sell it? Why do people need to buy it? So of course, now we don't want to create another, problem here. We understand, that's where the pain medications, problem came from. Okay, I'm not going to say anything about this. I guess this is probably not very important to us, but finally, this is the fun part. I know. So yeah, Dr. Herschler, Dr. Algeri, and me, and so now Dr. Algeri is in Syria. He's enjoying his life. We appreciate that. Okay, thank you very much. Feel free to ask questions. I hope we can still have time for the case. Yeah.
Yeah, Psychiatry Blues Brother. That's amazing. That's a great photo. I love that. Thank you so much, Dr. Zhang. You're very informative, great slides, and just very passionate. And you can tell you really love what you do. So that just spreads that energy throughout. So I really appreciate your time doing that presentation. I'll make sure everyone gets those slides. I did see a question, I think, hold on. What about ceiling doses of Suboxone from 16 milligrams to 20? So personally, I never used more than 16 for maintenance. I think our program, a lot of people are doing well, just 16 milligrams. So that's my experience. So should we increase to 60 ceiling doses from 16 to 20? I don't know. I mean, Dr. Herschler, Tony, and Dr. Hughes, that any of you can share, Dr. Reynolds. I personally, like I said, I did give patients when my patients have concurrent pain. I usually give them extra doses to help them with their pain, acute pain. Then I try to find a different way I increase the dose, but unfortunately, I just could not get a Medicaid approval. So usually, what I do is just write, self-pay like a prescription. But ceiling effect, I don't know. Per research, I think probably a lot of people use 24 to 32 milligrams. So believe me, you go to ASAM, you will hear a lot of stories about using 24 to 32 milligrams. Thank you. Does anybody else want to chime in, Dr. Herschler?
I was just going to say, when I used to work with methadone, one thing that happens is you push the dose up, is patients do what's called nodding, or they get sedated by the medication. They sort of are in a half stupor, a sleep state by the effects of the mu receptor. And so I think as you put, because it's a partial agonist, you may not see that as much, but there is risk of impairing functioning by escalating the dose higher. I don't work with doses that high. I tend to max out at 16. I've had one patient on 24 milligrams since I've been working with buprenorphine, so I'm not sure.
I was going to say, in the CTN trial that we're doing, we have people randomized up to 32 milligrams a day. And I was really reluctant to go that high at first. I was downright scared, actually, because, again, the experience was only 16 and nobody took more than 16. If you're taking more than 16, you're probably diverting it, which is still sometimes a concern. But the whole like over sedation thing, I have not really seen for the higher dose people. We've probably had now about 10 people that are on 32. And I'd say 9 out of the 10 have done really well on it. And just one person really didn't need that much. But I've been surprised at how well people have tolerated it. And actually, some of the people that have really struggled with our artificial cap of 16, and then they got up to the higher dose, have done really well. So a year ago, I would have said absolutely not. Now I'm more of a hard maybe, depending on the situation. So
16 minutes, actually, they did, in this presentation, they did presented a lot of data on like a ceiling effect. The real ceiling effect, actually, there's no ceiling effect on pain control for Suboxone. So in other words, you use higher dose, you may achieve better pain control. Even if we're talking about a buprenorphine, the injectable is a lower dose, FDA approved for pain, is usually 0.some milligram. So the second is for kappa receptor antagonism, which kappa we know is related to depression and anhedonia. We're talking about dysphoria, all this kind of symptoms. Basically, there's no ceiling effect. So in other words, your high dose of Suboxone may help with depressive symptoms, may help with anhedonia, and may help better with pain control. So the ceiling effect, we really, I mean, talking about the from research standpoint, it's really, I mean, I guess the ceiling probably is that, it will never occupy but after a certain dose, it will never, occupy more receptors to trigger the downstream pathway, which is kind of, that means the medicine is safe. Basically, it's not going to suppress the respiratory function and to cause overdose death just by using buprenorphine itself.
Excellent. Thank you so much for your feedback to the three of you. Does anybody else have comments or questions pertaining to the presentation? Well, if you do, please do chime in, use the chat feature, raise hand, don't be shy. And then unfortunately, Jennifer can't make it, but I'm happy to share her case. It was sent on in demand. So there are already suggestions in the post-recs. So I didn't know if you guys still wanted me to do that. If one of the hub members want to read through it, that'd be great. If not, we can always put it for another day for Jennifer. I just wanted to get your guys' feedback since we do have a little bit of time left.
More than happy to go over it now, but I wonder if she presented that. I'd love for her to get to be a part of that if there were kind of specific questions she had about it.
That's fair. We can just reschedule that if that's okay with everyone. I know that Dr. Zhang was trying to reference it a lot, which I really appreciate because she did have it was a really interesting case. So
don't let me speak for the great Dr. Zhang. Dr. Zhang, if you want to go over her case, since you did talk about it.
I think probably it's better to wait, wait for until she is here. But otherwise, we can, I mean, we're talking about buprenorphine dose. Actually, I think Dr. Husted actually treated a patient upstairs on DDU with higher dose of buprenorphine. I think it's a 32 milligrams. There's a 24 milligram. Can you tell us a little bit more about that patient and the overall treatment, progress? And what are your thoughts are? Yeah.
So I think exactly which one. I think I know one you're alluding to, but sometimes what I've done recently is one of the concerns is if somebody has been using a ton of fentanyl, going from 2 grams of IV fentanyl to 16 milligrams of Suboxone usually doesn't quite hold people. One of the tricks that I've been doing in the hospital, feel free to use it if you have the ability to, is sometimes going over the dose maybe temporarily. So pushing people to a pretty high dose while they're in the hospital. So for example, if you give somebody 8 and they still get sick, give them another 8. And if they're still sick, give them another 8. And there was a few times recently where I've had people up to 32 milligrams. And sometimes I'll just use pure Subutex at first, just until the heightened risk of precipitated withdrawal is a little bit better. But putting people on pretty high doses at first and then weaning them down to a more like stable dose that we use. And actually, if you look at the Medicaid guidelines, saying that 24 is okay for up to 60 days. I will say too, that if you have a really good reason to go above 16 and you can make your case for an appeal, you can get it approved. And I've actually had 24 milligrams approved recently for 6 months for a pregnant woman, which is pretty good. And it wasn't even just Suboxone, it was actually Subutex because she had some horrible nausea with Suboxone. So if you make a really, good case for why you're doing something, Medicaid often will say, okay. With private insurances, it varies, but it might not even be a problem at all, really, to go to a higher dose. So it's a good idea to be cautious about it. But if you have a really good reason to do it, the artificial cap by itself shouldn't hold you back. So again, it would be much rather taking 24 milligrams than using something on the street that's going to kill them. So kind of risk benefits.
Dr. Husted, just following up on that. So that's almost like a maxi dosing for fentanyl versus micro dosing, correct? Is that, because I've struggled with the same thing, and I found sometimes you just need to push higher doses and they're just not getting enough relief from it.
Yeah, it's kind of like one of the places, this is at ASAM as well. Dr. Zhang wasn't in this lecture. One of the places they do like a micro dose at first to sort of almost put somebody in withdrawal, and then they max out pretty quickly. So it's one of those weird things. If you put someone in withdrawal, historically, I think we'd kind of back off and not dose them enough, but really you should just push them high, especially if you have them in a kind of a sequestered, if you're in a controlled environment, then why not give them high doses if you can monitor them? So they're not going to divert it. That's hopefully they're not going to divert it in your hospital. But I think giving people high doses, at least stable, is certainly it's reasonable, and you can always use your P on top of it, your quantity.
Okay. Perfect. Thanks.
Mm-hmm.
Thank you so much, Dr. Houston. Thank you, David. And does anybody else have any comments or questions? Quiet. All right. So you'll get your 10 minutes back, and we'll reschedule Jennifer's for an upcoming date. And the only announcement I have is that Lindsay Acree is going to be presenting on July 11th for Narcan availability in the state. With that said, I hope everyone has a great weekend and a safe 4th of July. And I really appreciate everyone's time and all that you guys do again. So thank you so much, and you have a wonderful evening.
Dr. Houston is not wearing floral.
I'm sorry. Namaste. See everybody.